Hello, dear colleagues. Today we will continue our course about intelligent decision support systems. This course was provided by Gleb Nemkovsky, and I am your narrator, K.Koshechkin. And today we will continue with our goals of this module to take a look on medical facilities activities, describe the types, what are these organizations, their methods of payment to doctors. We will formulate the main characteristics of hospitals providing medical care and the way they are providing their services, how doctors are connected into the system. We will describe the main features of different approaches to payments for health services, including daily fees, global budgets, and pay per service flat fee systems. Identify other types of providers in addition to hospitals and doctors. We will describe the main characteristics of healthcare systems that combine several types of providers and describe the main features of performance-based pay structures and so on. So let's start with basics. What are the terminology adopted in this area? It will be, for example, based on Russian Federation approach, but it's common in general in all countries. So it is medical care, set of measures aimed at maintaining or restoring health, and it will include the provision of medical services. Medical services by themselves are medical intervention or a set of medical interventions aimed at the prevention, diagnosis, and treatment of disease, medical rehabilitation, and having an independent complete service to be provided to the patient. Medical intervention is a type of medical examination or medical manipulation performed by medical worker and other employers entitled to carry such services. So it will be some action related to the patient. It will be aimed on preventive, research, diagnostic, therapeutic, rehabilitation, and so on action carried by the doctor or healthcare professional. Patients are individuals who receive this medical care and who will apply for medical care and medical services. Regardless of the presence of the disease and his conditions. So it could be a healthy person, but in medical conditions, he will be called a patient. Medical activity, it's a professional activity in the provision of medical care, conducting medical examination, medical sanitation, anti-epidemic services, for example, vaccination, more complex services such as transplantation and so on. Medical organizations are legal entities, and they could be of a different legal form, and their main goal is to carry out medical activities as a main purpose of this type of organizations. And it's very important to talk about quality of medical care. It's a set of characteristics that reflect the results of medical care, correctness of the choice of methods, is everything done correctly, and will it help our patient or not. In other medical systems, we can have additional terminology groups. For example, it will be medical practice. So it will reflect actions of a doctor, and there could be group practice. It will reflect combined actions of a group of medical professionals. So group practices could include more than one doctor in a partnership, and such large groups could be called network. So we can talk about physician network, the group of physicians or practitioners which will provide medical services, and with this group we will be able to work from the side of insurance companies and patient organizations and so on. So if this insurance company is inside the network and the practitioner agree on the payment procedure, they will say that they are in the network for the payer. So this payment will be able to be received as a part of network of doctors. And another type is out of network, so it will be physicians who are not in the group of this doctors combined to receive payments from insurance companies. So it will be one-on-one patient payments to the doctor out of the pocket. So in general, they are not connected to the insurance companies. So for large groups, management take care of the work and negotiation with insurer. So in many cases, it's easier for doctor to provide his services as a part of such a group. And this network organizer will be able to work with as an association. So these independent healthcare service providers could be aggregated in an association of independent healthcare providers, and such organizations could also perform on the market as a part of the healthcare system. So let's continue with common payment methods, and they are quite easy to understand. They will be service fee, so you are paying for an invoice for each service provided. It could be volume fee, payment for complete case, hospitalization, treatment of illness, visit, and so on. And another way is to pay per capita for each person which will attend physician. So let's describe pay for performance system. Generally, it will refer to use of additional use of financial resources or penalties which are dependent on whether a provider meets some set of expected outcomes based on the set of predetermined metrics. And pay for performance system, also known as value-based system, is a payment model that offers financial incentives to doctors, hospitals, medical teams, and other healthcare providers for meeting certain performance criteria. Clinical outcomes such as longer survival and are difficult to measure, so this pay system typically assesses the quality and effectiveness of the process, such as measuring blood pressure, lowering its level, or counseling patients and receiving results from them. And here we need to talk about such terms, for example, tariffs, a list of services with an individual, which will indicate what is the amount of payment required for each procedure. So next one will be allowable amounts, and it will refer to agreed sums to be spent on a certain procedures. So we have a restriction not higher than such a sum will be possible to spend. Next one will be retrospective payment system. It will be invoicing for services and determining the amount of payment based on services provided. And this fee will be billed to the doctor's office and may be listed as a base amount, but often the amount which is provided by the insurer is lower than this base amount. And if we will talk about per capita payment, it will identify a group of patients, determine the scope of services, and it will require agreement between medical institution and the payer on a fixed payment amount, which will be associated with this group of patients. So we have a fixed amount to be paid for each patient with a certain medical problem. And if a patient will need additional services that are beyond the scope of services for this group of patients, for example, they could require additional hospitalization or will require consultation with a specialist or something like that, it will require additional payment per service. So it is common that per capita is a standard payment of the base level of services, and in addition, it will require per service scheme to provide these additional services. The amount of payment is determined before the provision of any services, and it will not vary depending on the services provided. The per capita payment may cover primary healthcare or may be extensive, and if any medical care from any provider or place of service is covered for a certain group of patients, we can talk about a global system of per capita payment for the group of patients. The per capita income rate it will depend on the amount of patients that will be able to provide the services. This scheme is broadly used, and global per capita payment should be much higher than the amount of narrower schemes. For example, primary care only per capita payment will be smaller than a typical services provided, payment for the typical services provided for the typical patient. Since the insurance risks are much higher, such schemes are used only by huge medical organizations or healthcare systems. Another type of payment provision systems will be occasional payouts, so it will reflect a clinical aspect, a set of services or medical conditions that must be included, such as a service fee, time spent for the certain patient in a certain period, and each episode will require its own payment for treatment for services provided. Another model is salary model, a fixed amount for working time of a certain specialist which will provide his duties and spend his time, and this time will be needed to be compensated. If we talk about which payments are received in these schemes by doctors and what risks do they have, with an intermediary pays for a doctor's practice using a per capita payment, even a particular per capita payment, they can transfer the risk from the intermediary to the provider. And let's say service provider receive a fixed amount of money for a number of services in their profile, even if the patient will need much more care. The provider is obligated to provide it, and it will result in losses for the healthcare provider. In the large service, for the large service providers, the easier way is to obtain statistically reliable data and predict its cost, and the risk will be reduced. Payments based on pay per service scheme will tend to create an incentive to provide more services or more expensive services. So in some cases it will result in provision of unnecessary services to increase these payments. On one hand, it will ensure that all services are provided and generated towards the meeting of patient needs. On the other hand, there is a concern that fees for services may create increase that lead to overuse of healthcare and increase healthcare costs. Per capita pay goes the other way. With per capita payment, healthcare providers have an incentive to provide fewer services to each patient. They will receive a fixed fee, and their financial situation will improve if they incur lower costs by reducing the number of services provided. This has its upside. It could encourage them to look for more cost-effective way to provide care that they could ignore under the per-service model. Therefore, the introduction of wages seems to be a good solution. At the same time, you need to understand that salary models work well only when doctors are employees for large medical organizations. For example, let's consider the simplest case when a small company enters into a contract directly with an intermediary. The intermediary will pay for services directly, possibly through the pay-for-service model. The medical practitioner will then be paid a profit-based fee through some methods, and they will develop to distribute these profits to the doctors. Another example will be to consider the possibility of practicing in a large group. The administration of a practice group can arrange payments through an intermediary on a basis of all the collective work of the doctors. It could be a paid service, or it could be some kind of per capita payment agreement, and group administrators can then take separate and different measures to pay individual physicians as salaries plus bonuses on based on the revenue from this service provision. And one more example will be to consider the case of small practitioners who have joined the Association of Medical Service Practitioners, and they will strike a deal with a payer to receive payment based on the collective work of the practicing persons. This can be a fee per person or service fee. Then, once the association is paid, it in turn will pay to the practitioners as agreed before. So, this is a some of the examples how it could be done, and in many cases these methods are chosen based on the situation, how big our medical organization is, how many patients do we have, and so on. So let's talk about medical organizations. The majority of them will be known as hospitals, and these organizations have facilities and staff to provide medical care. Hospitals can operate as public or private institutions, and on a for-profit or non-profit basis. In one country, hospitals will be more often owned by a state, and in other it will be private hospitals, so it could depend on the general work of healthcare systems. Defining characteristics of a hospital is its availability and infrastructure for inpatient treatment. In addition, hospital can provide outpatient care. What are the main characteristics of hospitals? It will be a level of services provided from basic to more advanced, all the way to tertiary and quaternary medical help. Hospital specialization, it will be related to what is the range of patients and diseases which this hospital could deal with. And hospitals which are able to work with variety of diseases will be called general hospitals, and another ones specialized in a certain area will be called specialized or specific center for medical service provision. Also, hospitals often provide training, and they could be a department of medical school, and they will actively support training programs for doctors. And in many cases, hospitals which are in a close connection with medical schools are called academic hospitals or university hospitals. So, how can the relationship between the hospital and doctor could be built in such a system? The simplest and most understandable option for doctors will be to be hired as a full-time employee in the hospital. A less common approach is an agreement between the hospital and the doctor to perform a practice, and in this case it will doctor will work as a independent medical service provider based in a hospital, and they will share their fees and their payments based on the condition of their agreements. In this case, we may encounter the concept of admission privileges. That will result in increase for doctors in their services provided in the hospital. So payment agreements could be an interaction between different and will reflect different ways depend on the and they will depend on the healthcare system in the country. In the case of insurance or paid medicine, medical manipulations and services uh, are to be uh, provided based on the payment, and these payments will be separately related to the medical care, provision of beds, and so on. So hospital will address these payments to reflect the system of the medical services provided. And it could be done for hospital as a network, so it could be a group of hospitals that insurer works with, and this system will recommend medical services to be provided, and it will reflect the global agreement from insurance company with a hospital network. For medical services, a fee for provision is related to the services provided to the patients. Hospitals have a list of all the services that the hospital can provide. All these services are charged, and the amount of hospital fees for each of them is already known. And it could relate to cost-based compensations, so hospitals will present their patient care costs to intermediaries, and the payment will be based on the agreed costs for the services which were provided. It could be daily payment. It is a payment for the patient for the day to stay in hospital. Hospitals and intermediaries set a fixed amount that will be paid to the hospital for 1 day of the patient's stay, and regardless the hospital's expenses or the costs incurred for the treatment or that particular patient on that day. Daily payment may vary by type of or complexity of services provided, by length of hospital stay, by the availability of dedicated services, and which services exactly were provided to this patient. So here we will approach to such called diagnostic related groups. It's a classification system for patient that has four main characteristics. So we will need continuously collected information about the patient condition at discharge, diagnosis, treatment, and hospital characteristics. And they are used to classify patient into a number of groups, and these groups are clinically relevant and economically similar. It's important to understand that the term diagnosis-related groups is used to refer to slightly different concepts in different countries. Some use this term mainly to assess diagnostically similar groups and direct payments, while other countries use these groups for budgetary allocations. So it will be for planning or to provide payment for the services. The active implementation of diagnostic-related groups system in the world began at the suggestion of the World Bank in 1990s, and regardless the specific needs of national healthcare system, this diagnostic-related group are implemented for several reasons. It will increase transparency of the hospital segment by classifying patients, measuring hospital profits, and it will help to optimize the costs of the hospital segment for the efficient use of hospital resources. In this payment system, hospitals are paid a fixed fee for each specific discharge, diagnosis, which means the hospital will receive payment for each patient based on the services provided to this patient. And this system has a method of assigning patients or groups based on the diagnosis. These groups are selected by algorithm using software, or so-called grouping software. Each diagnosis-related group is associated with a specific allowable amount to be spent on. One common way to associate each group with an allowable amount is to assign its weight that reflects the complexity or expected costs of the hospital to care for patient in a group. This program uses conversion factors to calculate the weight. Group weight in the value assigned to the hospital will reflect based on the characteristics of the patient rather than the length of stay or services provided. So hospitals will be encouraged to provide its services faster and to cure people in a quicker way to receive more income. So this system will evolve in time. It's adding additional groups, adding additional possible methods of treatment, and the weights of payment amounts for each group are usually calculated to relate to the average amount of care that a patient in a group may need to receive a certain level of treatment. For patients who need extra care, this grouping system often provides special supplements if cases meet certain standards. These payouts are called out-of-pocket payments. Diagnosis related group system usually operate with what's called presumptive payment. So we have a presumption of a level of payment which will be required for the patient in certain condition. Outfall payments are an addition for these patients to receive significantly more care than expected based on its group. So there will be always some patients which will require additional services, and this way will help to provide the services for this patient. Estimated payments are a way to calculate fees which are dependent on the patient condition at the beginning of treatment, and they are not related to the actual amount of treatment provided. So here we will come closer to the global budgeting, and each hospital will need to calculate its expenses and income before starting its work, because in the other way they will not be able to pay salary for their workers. And talking about budgeting, uh, we will need to talk about global budget model, a payment system in which a hospital is paid a fixed amount over a period of time. For example, state hospitals will receive global budget for a year. In global budget models, hospital must provide services within a defined list to the entire known or projected population. One of the main aspects of global budgets is that they are often work best of all or when they need to cover a large population. If not, it will be difficult to address just a few patients correctly, because it's hard to plan how many of them will be able to receive during the year. Global budgets are more difficult to use when there are many intermediaries, each with their own contracts with the hospitals, and you will need to calculate on the different terms how these payments will be received from these intermediaries. Different payment terms for inpatient and outpatient treatment also will affect the system. In hospitals, the patient is often more provided with independent treatment by, but treatment can also be extended into outpatient format. Payments for these two treatments are often separated, and hospitals can use a daily fee, or it could be based on diagnosis groups mentioned before, also for outpatient treatment. And another way will be to provide only inpatient treatment based on diagnosis groups, and outpatient treatment could be provided based on service. So it could be more flexible systems. Hospitals may enter into separate agreements with insurance companies to provide outpatient care, laboratory services, X-ray diagnostics, ambulance calls, and specialist appointments are just some of examples to be provided on a service-based payment. So, payments for inpatient and outpatient services could be completely different, could have a completely different approach. And also there could be a separate payment for the infrastructure and medical components. The medical services provided in the hospital have two main components: professional component, payment to the doctor and service provider, and another one is infrastructure component. It will be a payment to the enterprise for the provision of premises, personnel, or infrastructure that enable the provision of services. When doctors provide care as part of the private services, they are paying for the both components at the same time. In inpatient and outpatient healthcare facilities, the professional and infrastructure component may be charged separately. For example, in the case of surgery, the services of a surgeon, the services of anesthesiologist, and the use of hospital equipment will be separately included in the bill. So the amounts charged are often not the same as the amounts paid. Hospitals often send detailed invoices to intermediaries, even though they can be paid using the per dime or per capita or related to diagnostics group payment. And even when billing for services, there may be noticeable discounts for the amount charged. So let's talk about risks related to this payment systems. Hospital payment system can be uh, can reflect the risks which they are trying to reduce. The system of payment for the medical service carries the least risk or even bears it. All risks associated with the patients are in need for medical care are assumed by the intermediary. So these risks are carried by insurance company. The daily payment system transfer a certain risk to the medical institution since the hospital is paid for each day a patient is hospitalized. Hospitals are not in risk if a large number of people will need additional inpatient care. There is also no risk if patients need to stay in the hospital for a long time. At the same time, serious illnesses that require a large volume of services can carry certain risks to the hospital in the context of a fixed daily payment. These payments are made regardless of how much care is provided during the day or group of the patient and other factors. Hospitals will receive a fixed fee for each discharge. So now when a patient needs more days in the hospital or when they need more services per day, the hospital has to bear the associated costs. Drop-down payment components can help eliminate such risks. Global budgets carry the greatest risk of all, where hospitals have to have a fixed budget and take on the risk of whether people will get sick or not, and with variations in the amount of care which will be required to provide the services. So they cannot adjust their budget during the year, and they will need to allocate the resources which they have. So associated with this risk, there are various hospital payment systems created in different countries, and they could reflect, for example, when we have a system pay per service, it will tend to make the provision of more services, as if we will provide more services, the higher will be our revenue. So we will have the tendency of hospitals to increase their daily rates, which will affect the patients, and since payment is made upon the discharge, the hospital will benefit if it's available to discharge the patient as soon as possible. And if we have global budget, it's not a problem, and there is no such incentive, as hospital already have all the money that they will receive for the services provided, and patient could stay as long as she or he need to. So, as you can imagine, the paper service and daily payment systems have less risk for hospital, and they tend to underutilization of care, which is a good thing, but we can worry about overuse. For example, patients stay in the hospital longer than they need. With payments associated to patient groups, the global budgets uh, will work the other way around and tend to reduce the time of staying in hospital, and the patients are kicked out sooner than they need to. And it's actually a huge challenge to normalize the system and to make a good way to face these problems and make the system with less risks as for hospital and for patients. And we can provide several examples here, and based on Russian Federation, there is methods of payment for medical care which are established, and these general approaches are related to the tariffs for medical care provided, and these tariffs are fixed before the provision of services. And in general, the Russian Federation has adopted a combined payment system that combines all the main types of payment for medical services provided to persons insured under compulsory medical insurance. When paying for medical care provided on an outpatient basis, according to the per capita standards of financing for attached person with the expectation of the costs for a certain type of high-tech care and research, as well as funds for financial supports of paramedics and so on. In combination with the payments per unit of volume of medical care for medical service, for a visit, for an appeal, so it will combine different approaches in one system. Payment per unit or per volume of medical care for medical service and so on. When paying for medical care provided in an inpatient setting for a completed case of treatment or a disease included in the relevant group of diseases, for an interrupted case of medical care when a patient is transferred to another medical organization, prematurely discharged, of something like that. When paying for medical care provided in a day hospital for certain care being provided. So there are a lot of situations, and all of them are reflected in the ways they are being paid for. So in addition to medical practices and hospitals, there are other types of organization. For example, there are independent laboratories and independent diagnostic facilities, ambulatory surgical facilities, psychotherapy facilities, long-term care facilities, and so on. Most often they adopt systems and methods of payment for medical services. In the medical field, there are a large number of employed people who are not always directly related to the provision of medical care. In different countries, these may include nurses, technology assistants, psychotherapists, dentists, optometrists, and so on. A common way to provide payment for this specialist will be a salary model, and this payment for their services will be received by an organization where they are employed and not by themselves. Problems in the design of remuneration system. Salary design is complex process, number of questions that will arise, which set of measures should be used for doctors, what goals or expectations should be achieved, should and how should variation in patient characteristics be regulated, and how much money to transfer to doctors. Initially, records of patients, appointments, care, treatments, and so on were kept on paper. A set of such paper records was called a patient's medical record. Accordingly, the reposition of these records in the medical institution, the card index contains the medical records of all patients observed in this medical institution. Over time, it became clear that digitalizing this information could be beneficial for the system. The idea of electronic records would be easier to maintain and easier to search for information. In addition, the use of such electronic medical records will allow for faster and easier data transfer between providers, which in turn will improve the quality of medical services provided. In Russian Federation, the use of electronic medical records is regulated by standards. So, electronic medical records is an information system designed to maintain, store on electronic media, search and issue personal medical records upon information requests. Personal medical records are any record made by a specific healthcare professional in relation to a specific patient. Electronic personal health record is any personal medical record stored on electronic media, and the concept of electronic personal health record is in correspondence to EHR, electronic health record, and it's quite the same thing. Electronic medical archive, an electronic data repository containing all data sets, and it could be additional books, lists of patients and employees, navigation through them, search, visualization, interpretation, integrity, and other checks. Nowadays, term of electronic health records is also used. Unlike the electronic medical record used within a single facility, an EHR contains personal medical records made by different medical facilities. And personal records are usually found in the electronic application, allowing patients to record their personal health information for their own use, or possibly to share it with other healthcare providers. So, how do we know where, from whom, and how to get the data we need in our work? The following recommendations about the activities of organizations and their incentive, as well as data that's useful to point to when building a database, can be useful when creating AI structures. So we need to know our data, know its structure, and how it could be used. Data on the differences in goals of provider organizations and other interests in tools and innovations which are related to the size and structure as well as how they are paid can be important information. Not all service providers are equally interested in all innovations or equally able to manage them, even if they are increased the requirements for such a tools. So they could be just not ready to use them. Payments can make a good difference. Healthcare facilities that receive fees for services or related types of payments will be way more open for new technologies, innovations, if these technologies will affect their costs, their profits, and so on. On the other hand, it may be the case that provider organizations that receive fees for services or related payments may not be as eager to adopt new approaches that would reduce their services delivered, which could decrease their revenues. Organizations with a lot of risks per capita can benefit from introducing such technologies because it will reduce the services they are providing with the same result. They may be also particularly interested in finding ways to reduce costs and may not be interested in innovations that tend to increase resources which will be utilized for these patients. Larger and smaller organizations may also have different opportunities to adopt these new tools. Larger organizations may have significant internal resources to manage, and they will have computer systems and all the associated costs which are needed for such a technology. And smaller organizations often are not able to allocate such resources. And electronic health records can be useful sources of data, and the scale of organization can affect the value of this data. The problem with the electronic records is that they often not cover all the services provided in the organization, and the hospital payment data are not always connected with electronic health records. So you will need to combine all this information in one database before you will be able to provide anything as an intelligent decision support system. Regardless of the specific payment types, hospitals can send quite detailed invoices with patient diagnosis, procedures, and relevant information to intermediaries. So another way to receive this information will be to work with insurance companies. Please note that intelligent systems can be implemented in almost any area, and the level of medical care and level of population are not relevant, but you will need to adjust the goals of the system to address to an exact problem related with this population or healthcare provider or exact situation which will need this solution to improve it. So it's all for today. Thank you very much.